Hello, everybody. This is Dave with the SIR Resident Fellow Student section, again with one of our webinars. Go ahead and let me know if your audio is not working, whether or not we can hear you now. We're going to get started. We have, if you're interested in speaking at the end to ask a question, you can either type it into the question panel or go ahead and raise your hand and we'll unmute you. I'm going to give the microphone now to Amit. He's one of our active resident and fellow members, and he was integral in setting this up. So, Amit, the floor is yours.
Good evening, everyone. My name is Amit Baku, and I am one of the residents at Mount Sinai, Miami, in Florida. We have the good fortune this evening of having a webinar being given by Dr. Katharaine Krol, who is the interventional radiologist who's retired from practice, but did practice in Indiana. And she is the former president of the Society of Interventional Radiology and was very instrumental in the economic committee for the society as well. Dr. Krol?
Thank you. Gosh, it's so good to talk to all of you tonight. Thank you for being here. As I was trying to put this talk together, I was a little bit flustered as to what would be most helpful for you guys to hear about. So I put some things together, but I would also like to hear toward the end, we may talk a little bit about what you'd like to hear about in the future, what would be most helpful for you. So I put together some things that are more health policy and economics related, and we'll go ahead and talk about those. Let's see. Okay, so first of all, I thought let's talk about how do you get paid, because I don't know that they teach you too much about that in residency and fellowship, and it's really an important part, as we all know. So when you're going to get paid, you have to submit a bill, and there are at least two components to submitting a bill. You have to provide the CPT codes, which actually describe the services that were provided. And when you are choosing CPT codes, you used to be able to use codes that were kind of good estimation or in the ballpark, but several years ago CPT changed their nomenclature, and now it says you pretty much have to have a code that exactly describes the service or you shouldn't use that code. And then you have to report a code for the diagnosis. Currently those are ICD-9 codes, but those will be changing. They are going to change October 1st, 2015, and we're going to move to ICD-10. We'll talk maybe just a little bit about that for a minute. The ICD-9 has been in use for years and years, but it ran out of room and it can't expand. The rest of the world has been using ICD-10 for over 10 years. We have not wanted to embrace that. It is costing individual practices well over $100,000 to implement this. It's been postponed several times. It was most recently postponed at the beginning of this year from October 1st of 2014 to October 1st of 2015. And they are saying that that is a drop-dead date. There will be no more delays. So people have got to be ready for it. Basically, all carriers who are required to be HIPAA compliant, which is almost everybody, will have to go to ICD-10. And it will be an overnight thing. And if you're not ready and you can't submit your bills with ICD-10, and it's a whole set of issues, not just you have to know the codes and use them, but the computer systems all have to change, the software all has to change, it has to be able to communicate with the hospital, with the carrier, with your office, and if there's a glitch in there, basically you will not be able to bill and you will not get paid. There are a few carriers such as workers' comp that aren't HIPAA required, and they are probably not going to change, which means that if you're going to bill some of those outliers, you'll have to have software for both, which is a real pain in the neck, but that's the way it is for right now. So anyway, when you're choosing your ICD code, it basically should be the code that describes the diagnosis that led to the service that you performed that you are reporting. Typically, when you're reporting ICD codes for the diagnostic service, you're supposed to report the diagnosis that was why that diagnostic service was ordered in the first place. In other words, if someone was sent to you for a cough, and you do a CT scan and find they've got a big lung cancer, your ICD for the CT scan should be cough probably and not lung cancer, because lung cancer was what you found, not what the diagnosis was. So once you pick your codes, then it's important that you submit the bills as quickly as possible. Many carriers have deadlines for when you can submit bills, and the likelihood of getting paid decreases as time goes by if billing is delayed. Many institutions have, in the last few years, set very strict deadlines saying that our bills are going to go in within 24 hours, 48 hours at the most. And in order for the institution to bill, the physician has to have completed all the work, including signing off on the report. And if you are doing coding for the procedures, you have to get those coding recommendations in as soon as possible also. And if you don't do it within 24, 48 hours, you're probably going to get dinged or hear about it. In my experience, and what I've always taught, is that coding is best done by the physician who performed the service. If you are going to have the most accurate coding, it is done by the physician that performed that service. Of course, that depends on the physician actually having an interest in the codes and understanding, being familiar with both the CPT and ICD codes in order to get the correct ones. But the person that does it, if you've done the procedure, you are most likely to remember what was done, and you are most likely to capture all the components of the work that you did. And when you do the coding and the reporting, it sort of reminds you to document in the report all the different components of what you did. So it's in the report and it's coded, and so it's clear on both ends what was done. Some institutions have taken coding responsibility away from the physicians and only use coders and billers, and I know that is getting to be more common, especially when the physicians are hospital employees. But I think that if there's not communication between those billers and the physicians, that a lot is lost, and it leads to less accurate reporting and less accurate billing. When you're submitting a bill, the site of service where you perform the procedure makes a difference. If the services were provided by you in a hospital, the physician would typically report out the professional services, unless you're a hospital employee, in which case the hospital will probably report those services, bill for you, and then pay you a salary. The technical services, whether or not you are a hospital employee or not, are billed by the hospital, not by you. It used to be that there was a requirement that the physician codes and the hospital CPT codes had to match. It was never really enforced, and I think nobody really talks about that too much anymore. I don't think you have to worry about that. Physician services are coded with CPT, and they're paid using CPT coding and valuation. The hospitals, however, may not bill with CPT. They still report the CPTs and follow them, but their billing may be driven by DRGs, diagnosis-related groups, for Medicare patients, in which everything that's done to the patient during that hospitalization, if they were admitted for congestive heart failure, gets paid one lump sum. Or HOPS, which is Hospital Outpatient Prospective Payment Schedule. And again, those are kind of lumped, and all sorts of things may go into one payment group. You don't really have to worry about that, other than just to be aware that the hospital payment may not be completely driven by CPT, but physician payment at this time is still CPT driven. If your services were provided in a freestanding center, the billing may be different. Whoever owns that freestanding center will likely bill a global fee, which will include both the professional and the technical component. If you are an owner of that facility, then you'll get paid the professional component as part of your salary, and whatever profit is made on the technical component as well. If you are working there but you're not an owner, you probably still will not bill your own professional bill. It will be billed by the facility, and then you will be paid out of what they get reimbursed. When they're deciding what to pay you and how much to pay you and what to pay you for, carriers look at two basic policies. They look at payment policy and coverage policy, which are two different things. Payment policy says if a service is going to be paid, this is how we're going to pay for it. For Medicare, they're legally required to use CPT codes. They have some leeway to modify those, and recently they have become more frequently willing to say, well, there's a CPT code for this, but we don't exactly like the way it's constructed, so we're going to make our own code, and it's usually called a G code, and it's for the same service but has a little bit different structure, and they can say how much it's worth or how much they would value it for. But if they're going to pay for it, they almost always have to use the CPT codes and the valuations that are set. As I think Jerry talked to you about in the last talk he gave, he talked to you some about the CPT and RUC process. CPT is the panel where codes are defined and certain nomenclature is given to them, and that panel decides what's included in the code, what work is included and what is not included in it. And we try to be very clear on that. I actually sit on that panel now, and so IR has a seat at the table for the first time at that panel. Once CPT makes the code and defines it, then it goes to the RUC, the committee at AMA that values the code. And historically, CMS, even though they have the final say in the valuation, has most often rubber stamped whatever RUC said. But for the past few years, they have been going more and more on their own independently and saying, no, we don't agree with what RUC said. We think it's worth this. And whatever CMS says is the ultimate valuation of that code. We can go back and protest, lobby, argue, and try to get it changed, but usually that's not very successful. If you are billing a carrier that's not Medicare, they are not constrained to use CPT and the valuations of CPT. There's nothing legal that says they have to use the CPT codes for that service, and they don't have to use the valuation. Most of them do, but they are not required to. So that's the payment policy. Then you have to understand the coverage policy, and the coverage policy is the policy of each carrier that determines whether they're going to recognize a specific service and whether they'll pay for it. If they cover it, then the payment policy kicks in. But first they have to decide if they're going to cover it. Sometimes coverage decisions will be at a national level. We used to didn't see very many of those, but Medicare is coming out with more and more of those. Sometimes it will be a local decision, and even within Medicare, different payers across the country, different Medicare local carriers will have a different decision than somebody across on the other side of the country. So you have to know what your own local carrier decides, and they may decide that they will provide full coverage for everybody getting that service. There may be limited coverage for just certain indications, or they may decide that there's no coverage for it. And that's their prerogative. We can argue against it, and we often do, and we spend a lot of time and effort trying to influence coverage and payment policy from the level of the society. So once you know those things and you're ready to pick out which code you want, there's more things you have to know about. There's a thing called CCI Edits, and this stands for Correct Coding Initiative. And CMS has hired an independent group that updates the list of codes several times a year, and they are, I think, legally required to have so many codes in that list every single time. And this list determines CPT codes that shouldn't be reported together. And usually these make sense. For instance, code 37191, which is for placement of a vena cava filter. And the descriptor for that includes insertion of the filter, vascular access, vessel selection, intraprocedural road mapping, and imaging guidance, both ultrasound and fluoro, when performed. So this code includes vessel access, getting the catheter in the vessel, getting the catheter up into the cava. So if they were to get a report that has 37191 billed and 36010, which is the code for placing a catheter into the vena cava, you would probably get a payment that was for the 37191 and a denial for 36010, because that is included in the work of 37191. Some of these CCI edits are complete. They are just like never events. For instance, 36252 is for a bilateral renal arteriogram, and it can never be billed with 36251, which is unilateral renal arteriogram. You would never do both a bilateral renal arteriogram and a unilateral renal arteriogram in the same patient. Used to be, if the patient had more than one kidney, you could. But the new codes, these codes 36252 and 36251, preclude reporting more than 2 kidneys. So they're inclusive of however many renal arteries are on each side. So you would never, ever report those together. So that CCI edit is final and it cannot be overridden. Some CCI edits are conditional though. For example, that filter that we talked about, you can't report 36010 with the filter code, but you could report 36010 if it were performed for a different purpose from a different access on the same patient the same day. For instance, if you were doing thrombolysis of a DVT in the opposite limb and you went into that via the popliteal vein and put the catheter up into the cava to clean out clot in the vessel, you could code 36010 for that thrombolysis as long as the filter was placed from a different access, say the right common femoral vein approach or an IJ approach. So in that case, you could override the CCI edit by adding this modifier 59 to 36010. And lots of times people know they're not getting paid, and they know that 59 kind of works, so they just slap it on all their codes thinking that, well, you know, that got me paid, so it must be right. However, in order to override the CCI edit, you really do need to understand the rationale for the CCI edit and make sure that you document the reasons that what you did was different than the service that is excluded from payment or the service that's considered inherent to the other codes that are being reported. So you may add 59 and kind of be clueless and get paid, but that doesn't mean that it's going to work out all right, because if they find that you've done this incorrectly, they can make you pay the money back later at the very minimum. And if they found that you've done it intentionally, you may get much steeper fines than just having to pay the money back. And if you do it on 1 or 2 reports, it's not very much money, but if it's something that you do routinely and it's something that you do 4 or 5 cases of that a day, it can add up to a huge amount of money that you have to cough up. So sometimes you do everything and submit your bills and you don't get paid, which can be very discouraging. So what do you do if you don't get paid? First of all, you can review what you've done. You can review the billing. Did you submit the correct codes? Was a number turned around, or did something not get transmitted correctly? If that's correct, you can review the documentation. Did your report document all the necessary elements to report the codes that were reported? You can look at the reason for denial. The bills will have reasons for denial on there, and sometimes it may be it's a non-covered service, it's a non-covered indication, it's not part of the patient's plan, Maybe you're an out-of-network provider, either you or the facility can be. Maybe it was not pre-approved and it needed to be pre-approved. It may be that the carrier just doesn't understand what's going on and so they deny it. If there's a CCI edit precluding it, you can look and see, is it one of those that's a never event edit, or is it one that you actually met the requirements, and if you'd added that 59 and documented it, you could have gotten paid. Because you can go back and change all of these things or work on all of them if you understand why you didn't get paid. You can also review any local or national coverage decisions and find out, is coverage limited, and if it was limited, did you meet the certain indications that are covered and just not completely document that? Is there a way you could resubmit with documentation that would indicate that it was for one of the covered indications and you should be paid? If those don't work, there are other ways to keep going about this. You can write a letter to the carrier explaining what you did and why you think this should be paid. Even better, you can make a phone call to the carrier. You can do this before or after. If the patient, if they're denying the service even before and they won't give pre-approval, you can always pick up the phone and call the carrier. And what will happen is you'll get typically a low-level person who will say, nope, our policy is we won't cover that. Case closed. And you say, well, okay, and hang up, and they don't do anything else. Or you say, well, I don't agree with that, and they say, well, that's our policy. What you need to say is, I need to talk to the person above you. And they'll say, great, here's the name and number, and we'll have that person call you, or we'll connect you, or whatever. But you will always get to talk to the person above them. It's not an issue. And you just keep doing that until you get to the guy. If the first one you talk to is a retired pediatrician who doesn't know anything about IR, who has no idea what a UFE is, and no idea why you do an MR to diagnose fibroids and to plan a UFE, he's going to say no. But you keep working your way up until you get the person who really is in charge and who has enough clinical knowledge, or will listen to your clinical knowledge, or will accept documentation, articles, whatever you can submit to support what you want to do. And almost always that will work. Sometimes the patients can self-advocate. Sometimes national societies can do this for you. We do this a lot. You can talk to them. We'll often advocate for policy change if we need to. There's another thing called carrier advisory committees. The IR has a CAC representative at almost all localities for Medicare, and we have them in many localities for non-Medicare covered carriers as well. And those people can be really good advocates for helping you get through the system. And if it turns out that you're not getting paid because there's not enough clinical evidence and it's still felt to be unproven, hopefully as we move forward with registries, that will be a means for us to gather more data and do more literature documentation, more research, so that we can prove the effectiveness of what IRs are doing and reach a stage where we're not being denied for non-proven procedures. So all said and done, really when it comes down to it, the physician bears the ultimate responsibility for what codes are submitted and what charges are submitted. There should be a series of checks and balances to help you. The documentation you do, your reporting, should very clearly cover everything that's required to support the billing, the codes and the bills you've submitted. There is usually coding and billing staff or service who will at least double check your billing, or may do it on their own. And then most places will do periodic coding audits to help make sure that you're on track. What do you do, though, if you're a hospital employee and the hospital is doing the billing, or you're in a group and the group wants to do the billing and they're not letting you have a say in it? Unfortunately, you're still kind of ultimately responsible. So in some way, you need to take ownership of this and have at least some say in what is being billed. It's really advantageous to both sides to have communication back and forth. Coders can be very good, but they don't know clinical medicine, and they have to do so many reports a day, and often the IR reports are the most complex, and they read through it, but they may not catch what you did if they don't understand it. And so if you have their ear and can explain to them what you're doing and why, they can better bill for you or double check what you're doing. As ICD 10 gets closer, it is clear that there will need to be at least one physician champion working with the coders to implement these codes. It's not going to be just a one-to-one crosswalk, and you will need to help the coders. And again, a great opportunity for communication and working together to get the right thing done. They may not pick up an important component of the work you are doing, and you can help them by coding, and sometimes they may choose to not report codes because they think the documentation that you provided isn't complete and doesn't support a code, so they just don't bill it. Instead of coming to you and saying, you know, it looks like you meant to include this, we'd like to bill this, but we can't because you didn't say this, they just don't bill it. And if you don't have that communication back and forth, you and the hospital will miss out on revenue that you shouldn't. So if they would come back and say, you know, it looks like you want to use this code, but you're not saying quite the right thing, you almost always can adjust what you're saying and make it so that you can. What if your partners have a different philosophy on coding and billing? Sometimes others in the group may not worry about the consequences of incorrect billing. They may not be aware of it, or they may think that, you know, they're not going to get caught, and then they're getting paid, so therefore it must be right. And so they may upcode and bill more for the same procedure that you're doing, which leads to inequality in the RVUs that the group's reporting, and can make it so maybe you're not getting a bonus or whatever if you're not hitting the number that they're expecting, and that can be very uncomfortable. But they're liable if they get caught and punished. You may also be punished as part of that group. It may be that the whole group will get punished if they get caught. So it's something to kind of be aware of the group's philosophy as you're joining that group. Potential penalties can be big. It may be that you just have to repay overpayments, but it can also lead to the loss of your ability to treat Medicare or Medicaid patients, which can be big in IR. And it can also lead to a large fine. In addition to repaying whatever overpayment they paid you, you may be responsible for as much as $30,000 fine per case, which is can lead to a huge amount of money. Another thing that CMS is trying to do to discourage fraud is they now publish each physician's historical billing and payment. It's made public, and outliers will be publicly recognized, and they're hoping that this will decrease fraud and abuse. Basically, billions of dollars are spent each year in the United States on services that are either never provided or incorrectly provided or incorrectly coded for. And until recently, the government really didn't go after it. They had very few tools and didn't have any money budgeted for that. So instead, what they do, they decided we've got to cut costs. Let's just cut the cost for legitimate services for patients, which does in some cases curb misusage, but it also hits everybody who's not abusing the system, and it devalues good medical care. And people who are intent on misusing the system will just find new ways to do it. Fraud and abuse hurts all of us. Taxpayers are paying for services that aren't being given, and the providers are getting rich that are doing that, at least temporarily. Payments for everybody else universally go down to compensate for those billions of dollars being wasted on fraud and abuse. It's your tax dollars and my tax dollars that are being paid to people who are not providing good care. And it's a zero-sum game. There is a pool of money to be spent on patient care, and if billions of dollars are taken out for fraud and abuse, less is there to pay for good care. The good news, in a way, is that CMS now does have tools and is willing to go after fraud and abuse, and they are starting to do that. So just a little bit on fraud and abuse. There are gradations of this, and you can look on CMS website if you're interested in learning more detail. But I wasn't sure you guys ever talk about this in residency or fellow, so I decided to throw a little bit in. It can range anywhere from just making a mistake, and it can be typing in the wrong number, flipping 2 digits, and that's considered a mistake or an error, and that's a minor infringement. If they catch you, they'll just ask for the money back, or if you got paid less, they may pay you what you were owed. And then there are mistakes or fraud or abuse that's determined to be inefficiencies or waste, such as medically unnecessary services. And that would be, say you've got a patient who's in hospice and you decide they need a mammogram. That's probably not the right thing to do, and Medicare is probably not going to pay you for that. Then there are those who bend the rules and abuse the system by knowingly billing improperly. Upcoding is the main one there. And then finally, fraud is basically intentional deception, where you bill for services or supplies that were never provided to a patient. And the penalties are graded kind of like that. So why do people do this? To some extent, it's because the system is supposed to be relative, but our views are not entirely relative. The system's flawed, but it does have some positives, and the expert physician input is utilized to determine the values, and it's better than anything we have or any other proposed thing we have. But people look at it and say, you know, that's not what this is worth. I'm worth more than that, especially when you look at Joe Blow over there, who's fixing a toenail and getting paid 3 times what I got paid to put a carotid stent in. That's far-fetched example, but they kind of take it on themselves to correct mistakes of the system. Honest mistakes are made. In order to try to help physicians so that billing is more uniform, the trend for CPT recently has been to try to be more specific when we define the codes, so that those codes are used for a specific service. When they were vague, you could use it for a lot of different things, and they were used a lot of different ways. So a person doing an angioplasty in a dialysis access may get paid one way here, but they could bill it a totally different way across the street and get paid 5 times as much, which really isn't fair. Making the codes more specific can lead to some services not having codes, sort of like getting left out in musical chairs, but we're working on fixing that. So basically, what you need to know is you need to document what you did, and you need to document so that it supports the codes that you want to bill. To know what documentation you need to completely document what was done. You need to completely document the findings of what you did. And then you need to be familiar enough with the codes, both the ICD and CPT codes, that you can include in the report enough of a description that it meets the requirements to drive the billing. We're kind of running up on time. What's your pleasure? Do you want me to keep talking, or do you want to ask some questions?
I'd say I think you can keep going. I think we still have.
Okay.
Yeah, I think we can keep going ahead.
Okay, just break in when you're ready for me to stop and you want to do questions. So, for example, CPT code 76937, which is ultrasound guidance for vascular access. If you read the full descriptor in CPT, it says ultrasound guidance for vascular access requiring ultrasound evaluation of potential access sites, documentation of selected vessel patency, concurrent real-time ultrasound visualization of vascular needle entry with permanent recording and reporting. And you need to do all that if you're going to report this code. When we were trying to get this code, CMS was really concerned that cheap ultrasound units had just come on the market, and for a couple $1,000s people were buying what they called ultrasound machines that really didn't show them the vessel, but they could wave it around in the room and then bill for it. And CMS said, that's not good, we're not going to pay for that. and so we don't want this code. Well, we were able to convince them that when used appropriately, ultrasound guidance really is in their benefit because it makes the procedure safer and allows us to get venous access in patients that otherwise wouldn't have it. So they agreed to the code eventually, but they wanted it fairly tightly defined so that it excluded people just waving a wand around in the room and not looking at the vessels. So basically you need to meet all the elements of the code in order to report the code. Well, it was never intended this way, but coders and compliance officers have determined that those elements have to be documented in the report, which sometimes this documentation leads to long, wordy reports that don't have a lot of clinical significance, but that's what we're dealing with. So just telling your coders, I always save an image to the record. I don't want to put it in the report, but I always do this. In some places is not enough, and if you don't put that in the report, they won't bill that. Another example of understanding what you need to document would be like ICD codes. Currently, if you're seeing a patient with lower extremity vascular disease with an ulcer, basically all you need to say in the documentation is atherosclerotic disease with ulceration. And it's one ICD-9 code 440.23, and that's all you have to say. When we move to ICD-10, however, there's going to be over 200 codes to report a lower extremity ulceration, and over 100 of them to report lower extremity ulceration due to their atherosclerosis. And they break it down into all sorts of different things, including site and whether it's native vessel, bypass, what kind of bypass, is it right, left, bilateral. And if you don't make that change in your documentation, the coder's not going to be able to bill for it. So you have to understand what is needed for the coder or for yourself to pick the appropriate code when you're documenting. Another piece of how we get paid is quality reporting. It started out as paid for performance a few years ago and was initially a pretty low-hanging fruit. It was, you could get a bonus payment for reporting quality measures, and they were basically trying to give us training wheels to get us used to the reporting process and to get us to start thinking about quality in our practices. It's now morphed so that it's no longer bonuses, now it's penalties. If you don't report quality measures, you get dinged. It's only a couple of percent, but you know, a couple percent is a couple percent. Unfortunately, there have been very few quality measures that are specific for IR. We are sort of behind the rest of medicine, but the SIR took that on as a priority this year. They have submitted proposals for new quality measures for almost all the service lines, and we're hoping to see those implemented in 2015. I don't know if you guys have talked about structured reporting, but that is probably the way your reporting will go in the future, and it will have set fields that you answer, and those set fields should include the quality measures, which will lead to automatic extraction of those quality reports to CMS so that you and your institution don't have to do any further work, and you can get paid those bonuses just by filling in the blanks on those reports. Let's skip that for right now. I would like to talk to you about that, but let's skip that. We can maybe do that another night. Compliance, if you've not come across it yet, you will when you go into practice. Almost all institutions and practices now have compliance officers. They can be a friend, they can also be a foe. You need them though. They're there to make sure that you don't break any laws unintentionally or intentionally, and to ensure that patients' rights are met, and we are all in favor of that. Sometimes though they are so conservative that they go too far, and it results in not allowing things that would actually help patients and that you need to do. So it's helpful to understand where they're coming from. It's very helpful to have a dialogue and to be able to communicate with them. If they continue to block something that you think is absolutely right, you can do lots of things. First thing I usually do is just check with friends in practice and say, are you having trouble with this? And we kind of put our heads together. You can also check with SIR to find out if we have any guidance at a national level already in place that would help support your position. Practice guidelines, standards documents, coding guidance, all those can be very helpful. And the society does a lot of work to get those in place for you. So getting paid is a big reason why you should code appropriately, but there are other reasons as well. One is that if your department's not coding appropriately and they're not making the money or the revenue or meeting goals that they're supposed to, it can be very difficult for you to get the support that you need to run your department. Staff, equipment, catheters, guide wires, holding areas, all that they may tell you, no, you just can't afford it. When you're doing the work, you need to make sure that it gets billed appropriately so that you have documentation of what you're doing. You also need to understand that these codes aren't just used for billing. They're also used for all sorts of data mining. At a national level, they can be used by our society. We use them sometimes to try to answer questions and understand trends. But this is what tells the government, CMS, carriers, what's going on in medicine, where things are being done, what's being done, who's doing it, what diagnosis is being done for. And so in order to have an accurate database, good coding is part of where that starts. So let's see if anybody has questions. If not, we could go back and talk about diagnostic angiography, but I'd rather see if we have questions. And then I'd also like to hear from you what you guys would like to hear from us in economics. I debated whether I should put together a basic coding talk, Coding 101, how to use the codes, what they mean, but I wasn't sure if you're getting that from elsewhere or not. So why don't you tell me what you need.
Dr. Krol, first off, thank you again for agreeing to do the webinar and for your excellent talk. I think we all really learned a lot from it. To answer your first question in terms of our experience in terms of coding and all that, I think it kind of varies from institution to institution. Within the SIR-RFS, we started to try to put together a curriculum that kind of discusses that. But I don't think as of this point right now that we kind of have anything formalized that trainees or attendees can kind of go to right off the bat and kind of get a sense of. In terms of questions, I do have a few, and I think we also have some from the audience. In terms of ICD-9, when you were initially talking in your presentation, what are the key changes that you anticipate? I know that you had one slide where you're talking about specificity in terms of atherosclerotic disease and what have you, but not only from a procedural point of view, but also from like a clinical point of view, like when we see patients in the office or what have you. What are the changes that you anticipate or know that are going to be coming in the pipeline with ICD-10?
Well, here's what I am recommending is the ICD-10 book is this huge volume, but you will only need a tiny percent of them. At SIR, we are developing kind of a cheat sheet that you can use to start with. And then you kind of look at your practice and say, what kind of patients do I see most often? And then you need to read those sections of the book and understand. Some of the big changes are being more specific about unilateral and bilateral. In the past, that's not been the case. And in this case, it's very site-specific. But it's all across the board. Some of it will be a one-to-one crosswalk, but most of it won't be. So I think look at what procedures you do, what kind of patients, what kind of diagnosis you typically would see, and then come up with a cheat sheet that will help you and your coders.
Got it. One of the things you also talked about was in terms of CMS and kind of how they decide reimbursement values, whether and whether or not they take the recommendation of the Resource Utilization Committee. As trainees who are kind of entering the specialty, what would you recommend that we do either on an individual or as a group on a group level to ensure adequate reimbursement in terms of advocating for the CMS? Obviously, being involved with SIR, but is there a role for us to individually contact our members of Congress or people who we may know that have a voice in the final process?
Well, my recommendation is that SIR is your voice for advocacy. ACR is also a big advocacy group, but they advocate for big radiology, and SIR really has the interests and the needs of IR. And we have excellent economics people, we have an excellent guy on the Hill, and if we coordinate our efforts and use everybody's talents together, I think we'll have the strongest voice. And we do a lot of advocacy, both with CMS, at CPT, at RUC, on the Hill. And I think as you see problems and as you face problems, SIR should be the first place you call up and say, hey, I'm having this trouble, what can I do, who can help me? And if they don't give you the right person, just keep asking, because we have those resources and we can use those resources together. And if you're interested in being involved, that's the place to be involved. If you've got interest, talent, skill in that, they will put you right to work. And really, it's a very engaging thing. It's kind of a nerdy thing to do at first when you think about it, but it's patient advocacy, because if there's not a payment policy, there's not coverage policy, patients can't get the care that they need. And also, if you just sit back and say, gosh, look what they're doing to me, instead of being part of it and saying, what can I do to help the system? How can I make this so that at least there's expert input when they're making these decisions?
Got it. Kind of following up on that, we have a question from the audience, and it's what measures does SIR take to ensure that appropriate value and compensation are attached to each of our codes?
Well, we spend a huge amount of time and effort on that. We are very active in defining the codes, and we're very careful about when we take codes to CPT, because there are ramifications. If you ask for a new code, CPT and RUC may look at it and say, oh great, we'll give you a new code, but we think these other 10 codes now have to go back to RUC and get revalued, which always means less value. So we're careful about when we take things to the CPT panel. But then, once we know we need a code and we're going to have to do the valuation, we have expert members, and we know who our members are and who is doing various procedures, and ask them to fill out these surveys. And they're about 15-page surveys for each code that asks you all sorts of questions about how hard it is and how much physical work it is, how much work you do ahead of time, how much time it takes during the procedure, how likely you are to get sued, how many different diagnoses do you have to consider when you're considering what the options are, and all sorts of questions. And then those are pooled, and if it's just a code SIR is submitting, we'll submit that to the RUC. Usually we submit codes in conjunction collaboration with other societies, so we all pool our data, and then we go and advocate at the RUC for what value we think, and we give it everything we have to get as much value as we can. If it doesn't get the value we want and we think it was wrong, we can appeal that. We have done that before. We can appeal it with CMS if we need to. We do a lot of work with local carriers as well as national carriers on coverage policy, advocating for coverage.
Got it. And Dr. Krol, in terms of one of the things you spoke about in your presentation was talking about how, if there's discrepancies or questions in terms of coding to meet with your coders who do the billing. In most training institutions and fellowships, the fellows or the trainees or the ones who are senior residents are the ones who are usually doing dictating the notes down, depending on the attending preference. Would you recommend on a routine basis that fellows early in their training meet with the coders to try to get a sense of make sure everyone's on the same page and that the value that you're capturing is actually what you deserve to be paid from the procedure?
I think that'd be very helpful, and just get you on their good side too. When you let them know that they are important and you acknowledge that they exist, I think they'll do anything they can to help you.
Got it. And one of the things you talked about, kind of along the same lines, was in terms of structured reporting. Do we know if currently there's anything in the works on SIR's end or in any particular institution that you may be familiar with in terms of structured reporting, in terms of what specifically needs to be in a report, or if there's a specific template that is followed society-wide?
Yes. those are very close to rolling out, I think in beta model. I think there's probably 7 or 8 procedures that the templates are pretty much completed for, and they will be in certain institutions in the next year, and those institutions will be, the data from that will be extracted to the national database, and we'll be able to see how it's working. But we're pretty close to the beta project, and then we're hoping to have it rolled out wider in a year.
Excellent. Thank you, Dr. Krol. One final question for you from the audience. With the new IR/DR residency being enrolled in an environment of increasing competitiveness and decreasing reimbursement, do you think a formalized business curriculum should be mandated in the new residency training curriculum?
I think business is critical, whether it's mandated in the residency or whether it's something that we can do in webinars like this and put together a really overarching, well thought out curriculum that can be accessed by all programs or by all residence fellows, recent fellows. When you get out into practice, they'll start to make more sense too, and then you need the information. So if we put it somewhere where you can get at it and it's well organized, I think that would be the best way to do it, personally. And then anything that your staff can do to help support that is excellent as well.
Great, thank you. Dave, I don't know if we have any last-minute questions from the audience. I don't see anything, but I just wasn't sure if you saw anything on your end.
We're getting a lot of thank yous. We're getting a lot of interest in people having future sessions like this, and thank you, Dr. Krol.
Thank you for inviting me.
No.
I'm so glad to have all you bright people going into IR. You know what? I retired from clinical practice, but I loved what I did. I was so fortunate and so lucky to be where I was, and you guys are going to feel the same way.
Thank you, Dr. Krol. We really appreciate your time and your expertise in the subject.
Thanks for inviting me. Have a good evening.
You too.